I am Dr. Kanzaya Machandio, the CEO of Experience Dentistry. And once again, welcome everyone on the day two of Maxillofacial Fracture Virtual Summit. It's one of a kind of Pakistan's virtual summit that we are conducting. Alhamdulillah, we're so proud of it and so proud of the team that has organized it. This summit is a significant milestone for everyone, the organization Experience Dentistry, and for the people of the dental community, for the medical community, and as well as the people of Pakistan and all around the global for to have more maxillofacial awareness. Let's move on. Um, I would like to pass this. I would like to introduce Dr. Mahrukh Nisar, sorry, a highly distinguished consultant maxillofacial surgeon and assistant professor at Avicenna Medical and Dental College, Lahore. She serves as a consultant maxillofacial surgeon at Farooq Hospital, DHA Lahore. She is a gold and a silver medalist from a prestigious Army Medical College. She completed her FCPS in oral and maxillofacial surgery and received advanced training at the National University of Singapore. Driven by the deep passion of facial surgery, Dr. Nisar is committed to demystify complex surgical concepts and inspire the next generation of surgeons to deliver precision and purpose in their work. Let's begin.
Okay,
Assalamu
Jigar.
alaikum, Dr. Mayak.
Walaikum assalam, Kanza. Thank you for having me and thank you for such a good introduction. I am
We are
truly
honored to
honored.
have you on our platform.
Thank you, thank you. I'm truly honored to be a part of you guys. You have given the introduction, so I would just jump up to what I have to tell you all today. I will be talking about accurate diagnosis and imaging of facial fractures, basically, for the Maxillofacial Summit today. So I would just move on to the first. I am not a fan of didactic lectures, so I would start with a case scenario with you guys. There's a young motorbiker. He comes to the ER after road accident and he's awake. He's bleeding from his mouth and his face is swollen. So, in that moment, we know that every second counts and the decision you make will shape his recovery, both functionally and aesthetically. So, as a receiving doctor, what will be your first step? Since I do usually go on to the two-way talk with people and my students. So I would expect a response generally, but if we don't have anyone to respond here, so I can just move on. Okay, we would want to note as a receiving doctor, the first thing the person is going to see would be the ATLS protocols are being followed or not. Uh, Airway, breathing, circulation, disability, and the exposure. But the recent advances by the 11th ATLS say that you have to stop the external bleeding first. Whatever exsanguinating hemorrhage is happening, you have to stop that. So if he's bleeding from his mouth, you have to put a pressure pack, you have to stop their bleeding, you have to ensure that there is no life threatening injury according to the ATLS protocol, and then move on to what you can do during the secondary service. So I assume we have undergrad people listening and we have young dentists listening, so they would know the ATLS protocols very well. Now, once the ATLS is done, the next part, which is the secondary survey part, that's where your diagnosis comes. So I would be, touching about that today. So, the learning objectives today that I want to achieve by talking to you all is to understand the common facial fracture patterns, to learn the systemic approach to diagnosis, and to identify the appropriate imaging modalities, not just the list of modalities you can have, but which modality to use where and would that be sufficient or not. That is what I'm going to touch upon today. So, just a brief intro because on this you can have a lot of chapters and chapters of the facial trauma anatomy. But bare minimum, if I have to, because we have from the posters I gathered, we have third year students as well, undergrad students, and we have young dentists as well. So, you divide the face into three thirds. There's an upper third, middle third, and lower facial third. The upper third, if I could point here, it's from the hairline to the supraorbital rim, and then from the supraorbital rim to the base of the nose is your middle third, and from the base of the nose to the lower aspect of your chin is your third, lower third of the face. So you would divide the fractures in these thirds, and that is how you move on. Plus the buttresses. Allah Miah has blessed the face in such a way that the face is like a matchbox or like a tent pole, so it takes most of the pressure in trauma. It takes the force and it crushes in a way that the energy is not transmitted to the very important organ that we have, which is brain. So the energy is not transmitted to the cranium. So for that we have buttresses. These buttresses not only form a tent, these buttresses not only guide the reconstruction of the facial trauma, but they're also very significant in identifying where you can feel the fractures. So you have four horizontal buttresses and you have four vertical buttresses. The horizontal buttresses, as pointed out in the figure B here, there's the supraorbital rim, that's the one. Then there is the infraorbital rim, there is the hard pellet, and then there is the mandible. So this becomes your four horizontal buttresses. And for the vertical buttresses, there is one nasomaxillary buttress, there is one zygomaticomaxillary buttress, there is a pterygomaxillary buttress, which is hidden here, and there is the vertical rami, which is your last vertical buttress of the face. So, why this is important? Once you are imaging or you are diagnosing something, you are going to find the fractures across the horizontal buttresses and across the vertical buttresses, and that will help you in even planning what you want to do with the patient. Okay. So, moving next, just briefly touching upon the fractures. Mandible fractures, you would find them in the condyle, angle, body, parasymphysis, and symphysis. People confuse mostly parasymphysis and symphysis. Symphysis is strictly midline, that's between your incisors. And anything from middle of the incisors to the canine is going to be your parasymphysis. Beyond that is body, and at the angle, the third molar, there are tons of definitions for angle fractures. I'm sure the students would be well versed with them. But bare minimum, any fracture that is posterior to the last standing tooth in the mandible is going to be an angle fracture. And then you have the vertical rami fractures and the condyle fractures and the coronoid fractures, or you can have complex fractures, bilateral mandibular fractures that you can encounter in mandible. Next, our favorite Lefort fractures. Lefort basically identified these in 1901, but these are still very relevant theoretically and even in identifying your fractures or communication amongst the surgeons. We have to tell somebody what kind of fracture they should be anticipating when we are transferring the patient or we are sending someone to the OT. So for the maxillary midface fractures, the Leforts are a good communication tool. You know, the Lefort one is a horizontal fracture just above the apices of the teeth, and that separates the maxilla, the lower maxilla, from the rest of the higher structures. The Lefort 2 is from the nasion, and it goes like a pyramidal fracture back to the pterygoid plates, and that separates the midface from the cranium. And then finally you have the Lefort 3 that just separates the entire middle third from the higher structures. You would never find you would never find a very classic Lefort 1, 2, 3 fracture just like the pictures, but there's a combination of zygoma fractures, there are a combination of mandible fractures, or it can be unilateral. Very rarely it can be a classic Lefort 3 or 2 bilaterally present. And along with that, you have other fractures from the mandible as well. Then you have the zygomaticomaxillary complex and orbital floor fractures. With these zygoma fractures, you must almost always expect to have a fracture of the orbit, the bony orbit. You must always be expecting to have that. With that comes the amongst the orbital floor fractures, you have mostly the blowout fractures in which the orbital contents herniate into the maxillary sinus. And then you have the nasal bone and the panfacial fractures. Nasal bone, isolated nasal bone fractures are also present, particularly in the interpersonal violence cases. And the panfacial fractures are the ones in which you have at least one bone fracture in each of the thirds of the face. That's one kind of consult. And recently, there is the ideology that you're going to have at least fracture in the at least 2/3 of the face, so that would be counted as a panfacial fracture. Now, touching upon the kinds of fractures mostly we see, So systematic diagnosis and the approach to diagnosis is important, and that is what I want to emphasize here today. Fun history, the mechanism, time, symptoms. Usually, from the maxillofacial fracture perspective, unless there is aggressive bleeding, unless there is some mandible that is going to occlude the airway, that is going to cause obstruction of the airway, we deal with the maxillofacial fractures in the secondary survey or after the life threatening injuries of the brain injury or the airway, breathing, circulation have been dealt with. So we can identify and then deal with them in an appropriate manner at a later time. This is the kind of, you can say, beauty of being a maxillofacial surgeon. But yes, you have to be very well versed with what you want to do if you are first in line as well. But we do not fall into the first in line category, we come as second line specialist for trauma. So, if I can elaborate to you on this picture, on one side, it is the soft tissue things you're going to see in the patient, and beneath that soft tissue envelope, you're going to see the hard structures, what you would anticipate. Like if you have subconjunctival hemorrhage in the eye, you would expect to have a fractured zygoma. If you have a circumorbital ecchymosis, you could expect to have inferior orbital rim fracture. That would be again a zygomaticulo-maxillary complex fracture. We'll be pointing right in your face that yes, it is present here. Then you have bruising ecchymosis anywhere, though it would be pointing out that there is, suppose the bone beneath has to be explored upon to see for a fracture that might be hidden or present. Okay. And then functional assessment. If you have paresthesia on the face in the infraorbital region, so that paresthesia is going to dictate that yes, in the zygomaticulo-maxillary suture area, there has been some at least separation or a compression injury has been there, which is causing this paresthesia or anesthesia or entrapment of the nerve. So that has to be explored upon and that has to be dealt with, because it can be kind of very irritating and very debilitating for the patient in a long term. So we have to limit the morbidity by identifying the fractures at first and then dealing with them. Okay, so the best part, imaging. Mostly in undergrad level, there is going to be a very big list of the imaging. When you ask a student, what imaging can you do for a mandibular fracture, they're going to give you this 10 in this list of plain x-ray, CT scans, MRI, everything. Now you don't do everything in every fracture. You have to identify your resources, you have to identify what would suit the patient best. But worldwide, the gold standard for trauma is CT scan. CT scan, a voxel based CT scan with 3D reconstruction, is the gold standard for trauma. Now, you might be in a BHU, you might be in a periphery area where you might not have access to CT scan. So, what to do? Then comes the plain radiographs. For mandible, you can have OPG, you can have PFAce, you can have Townsview. Townsview is not usually done in Pakistan, but Townsview is done worldwide in case you don't have a CT scan, because CT scan is definitely the gold standard. If you don't have CT scan, then you go on to the other fractures. If you're suspecting a fracture of the mandible, you go for PFAs, you go for an OPG. You need two radiographs basically for mandible. There's this concept, you need two radiographs at right angles to each other. Okay. So there's the OPG, that's a panoramic view, and then there's the PFAs that is going to give you at right angles to the OPG. I hope I am getting this across. So that's for the mandible. For the mid face, the best X-ray you can have is the Waters view. It's also called occipitomental view. SMV is the submental vertex view, that's perfectly isolated for a zygomatic arch fracture, but you don't do it usually. It's only done when there is a isolated arch fracture. CBCT for dentoalveolar fractures, it's a limitation of the radiation dose and everything. It does a targeted 3D view of the dentoalveolar structures. That's pretty nice. Then you have the MRI. Now, usually MRI is for pathologies. MRI is not for trauma. But if you have a midface fracture and you're suspecting an optic nerve traumatic neuroma, or you're going to have optic neuropathy that has occurred, or optic nerve sheath hemorrhage. So that would not be very visible in a CT scan, even in a 3D reconstruction CT scan or a voxel based CT scan. So with that soft tissue, you might go for an MRI to see the nerves or certain affiliated soft tissues only. That's like 0.1% of the time. So MRI is not for generally trauma. Okay, I think I have made this clear. Let's review a little bit further. So, choosing the right imaging, you have to match the modality with the suspected fractured site. Like for midface, there is the occipitomental, which is your water view. For the mandible, you have OPG, you have PF face. The midface and suprastructures are pretty much covered in the water view. That's for plain radiographs. Otherwise, you can go for the CT scan. And unnecessary scans have to be reduced. One thing I want to make a point across, if you are working in different hospitals across Pakistan and even abroad, when a patient comes with a trauma, a roadside motorcycle accident, or interpersonal violence, falls, or anything, according to the ATLS, people go for a CT brain to identify brain injury. Now, in CT brain, while getting a CT brain, you can add face in that. So the radiation cost and the repeated scans, they can be avoided. Once the doctor is ordering a CT brain, you can have CT brain plus face. So you go for the facial structures in the first scan, and you don't have to take the patient again to a scan at a later date for the maxillofacial fractures, because with brain injuries, with high velocity injuries, almost 50 to 60% of the times there are facial fractures associated, but you cannot operate upon them unless the patient has been stabilized by the neurosurgery department. So to avoid unnecessary scans, you can have the scan done initially. So that was one point I thought I should make it across to the audience. Now, for plain radiographs, like I said, the Waters view is excellent. Without exaggeration, it is an excellent plain radiograph for your mid-face and suprastructures. There were certain lines that have been demarcated theoretically and even clinically. So, for a layman to identify whether there is a fracture or not, there were certain landmarks that were created by, on the left of your screen, you can see the Dollins line, and on the right of your screen, you are going to see the Campbell and Trapner's lines. They were created that if somebody is looking at this X-ray, how would they know there is a fracture? So they said you can, look across these lines and identify any gap or separation or break. So in the left, there is the line 1 is the zygomatic pillar buttress line, 2 is the orbital line, and 3 is the maxillary buttress line. So that was one given by Dolan. And the other, I prefer the right one, which is the Campbell and Trapnell's line. There is one across the supraorbital rim. So you look across, when you are looking at an X-ray, you look across the supraorbital rim and see for any breaks, any separations, or any fracture lines there. That's one. Then you look across the infraorbital line, the second one. You're looking across the infraorbital, you're scanning through, and you're looking, comparing one side to the other, and you're looking for any breaks in it. And then the third is your maxillary line, where you're looking at the sinus walls and the maxilla, and that is how you're looking for any break in it or any abnormality in it. And then you go for the occlusal plane, there would be any step, there would be any break in it, loss of continuity. That is how you identify the fracture there. And finally, there is the fifth line that was added at a later time, which is the mandibular line. So you look across the lower border of the mandible and you identify if there are any break in that, in any variation. So the smooth line is not smooth and there is certain break or crack in it. You can see, yes, there is a fracture here. So for a layman or for somebody who is not very adept at it, following these lines, looking at a plain X-ray, you can definitely pick up a fracture if there is any. Next, the thing I was explaining before, which was about mandibular fractures, how you can do this. On the left, there is this OPG, which is a panoramic imaging, and on the right, there is the PFAs. So I just don't want to go into the details of it, but there is a concept of favorable and unfavorable fractures. So in case you miss any, once you're doing that at right angles, you have two radiographs at right angles to one another, you would definitely not miss any fracture line that might not be present on the OPG, but you can pick it up at the PFAs. If it is present on the PFAs, if it is not present on the PFAs, you might even pick it up at the OPG. So that's why if you are unable there's if you are unable to identify a fracture clinically, or you have a hint that there is a fracture in the mandible and you cannot go for a CT scan, you go for these two radiographs. Next, as explained, the gold standard is going to be the voxel based 3D CT scan in trauma. Here it's 3D reconstruction on the top left, and on the top right it's the axial view. On the lower left it's the coronal view, and on the right lower area this is the sagittal view. So in CT scan you would want to have all three views along with the 3D reconstruction. So you sift through the slices. They have to be at least 1 to 1.5 mm in their thickness or in the cuts. So you won't definitely not miss a fracture. If I can just tell you on this 3D reconstruction, there is steps in the infraorbital areas and the maxilla. So the maxilla is separated just above the apices from the suprastructures. The mandible is fine, and thus the other slices are also focusing on the maxilla. There's break in continuity on the right side, and then in the coronal view, you can see that the sinuses have been filled up with blood or fluid for that matter. So you're looking at something that is hyperdense in the right side of the face. Usually your sinuses are air filled. So in x-rays or imaging, if there is fluid present in one sinus that is not present in the other sinus, that would give you an indirect sign that yes, there's some break or some fluid extravasation into the air spaced cavity. So that would hint you that yes, there is some fracture here, and you would reach a good diagnosis of it. Same goes for the last sagittal slice. There is extravasation of hyperdense fluid into the sinus. So that is indicating that it might also be possible that the floor of orbit has been fractured and there is some herniation of fat and material into the sinus. So this is how you're going to keep on linking your clinical evaluation with the radiographic evaluation, and that is how you ultimately reach an accurate diagnosis of a facial fracture. Now, there are multiple instances where you miss a fracture or they heal abnormally, and at a very later time, the patient presents with a delayed morbidity like nerve issues, nerve paresthesias, malocclusion. All of these hints just point out to how you would be able to follow some the surgical or the diagnostic sieve, which involves history first, clinical examination, a very good clinical examination, moving on from the extraoral to the intraoral to identifying each and everything, and then going on to the radiographs. I would summarize this further in the later slides so that we are able to sum it up, or the key takeaway messages that the listeners would be able to match the dots and practice in their respective clinical areas. So, we know that early diagnosis is going to prevent disability and even functional and aesthetic outcomes in the maxillofacial trauma. So, address the life threatening injuries first. Obviously, you're going to address the airway, breathing, circulation, disability, and any other bodily fracture that is going to be life threatening for the patient first before moving on to the maxillofacial fractures. And then ultimately, there's the right imaging that leads to faster treatment and fewer complications. So, to sum it all up, just in like 2-3 minutes, if I have to, as as a dentist, as a undergrad student, or as somebody who wants to pursue later on any specialization in our dental fields, for us, one thing that's very remarkable is our occlusion. So once the patient presents to you with the facial trauma, there's going to be an aesthetic problem, then there's going to be a functional problem. Aesthetic is the face, definitely, and the functional problem is going to be the occlusion. Most patients present to you only with the complaint that I'm unable to chew, I'm unable to eat, I used to eat normally, my teeth don't close down much, and they suffered a roadside accident or a motor vehicle accident somewhere like a week or more back. So as dentists, you would be identifying what? You would be taking the history that what happened that led to this change, and you will be doing the clinical examination. Extraoral, intraoral, I would not go into the very much details. That would turn into a very didactic lecture if I go there. So extraoral, intraoral examination, and then going for the appropriate imaging, which for trauma is going to be your 3D CT scan. That's the gold standard. And depending upon your resources, patient's expenses, or the uh, severity of the condition, you can go for plain radiographs or CBCT or MRI at a very, very minute number of cases where nerve injuries are involved. Right? So I would just sum it up here. And these are the resources you would want to go. AOCMF is a very good site. It's very easy to navigate through. So you can go for uh, specific chapter based studies there as well. So I would advise people to do go for the AO CMF or AO surgery references, Bailey and Love, Atlases, and Radiopedia from where I gathered the stuff for this. And thank you. If any questions are there, I would be up for it. The house is open for questions. Thank you.
Thank you so much, Dr. Mahrukh. We have few questions.
Yes, yes.
If MRI facility isn't available, then what is next best option for soft tissue imaging?
That depends on the kind of injury you want to see. If you want to see a nerve injury, you can go for ultrasound imaging in such areas. The facility, if not available, or referral option is always there, because soft tissue injury is not this soft tissue injury, it's a nerve injury that you want to see in trauma. Otherwise, CT scan is sufficient enough. For nerve injuries, you can refer the patient to get an MRI, because nerve injuries would demand a neurovascular repair by a neurovascular surgeon. I hope I've answered this.
Yes. Fatma Zahid said, "Thank you,
Oh,
Dr.
yes.
Maru, for such an insightful session. It was truly a privilege to learn from you once again, having been your student during my time at Avicenna."
Oh, thank you, Fatma. Good to have you here, yaar. Fatma was a very bright student of ours. Thank you.
Uh, no more questions. Thank you
Okay.
so much, Dr. Maru, for such an insightful session.
Thank you so much. Thank you.
Hassan Javed said, "Thank you so much, ma'am." Dr. Maruf, we have few more comments. Thank you so
Yes,
much,
sure.
ma'am. Hassan Javed said, and Abdul Hafiz said, "Thank you so much for amazing session."
Thank you. You're welcome.
Aina Fahim, amazing session. Thank you so much, ma'am. We are extremely grateful to you for delivering such an insightful session. Your expertise in maxillofacial surgery was delivered in a way that was both accessible and inspiring.
Thank you
Moving
so much.
towards next speaker, Dr. Mujtaba.
जी जी
Assalamu alaikum, sir.
अस्सलाम वालेकुम सलाम
Assalamu alaikum
Now you can
everyone. I welcome you all to today's session. My name is Dr. Rumesa Javed. I am Marketing Manager of Experience Dentistry. It is my pleasure to introduce our guest speaker, Dr. Mujtaba Nadeem, an accomplished oral and maxillofacial surgeon. Dr. Nadeem completed his residency in 2022 and is currently serving as an assistant professor at Avicenna Dental College. Alongside his academic role, he runs his private practice, Grand Dental, in Lahore, where he not only helps patients restore their smiles but also dedicates his time to mentoring and hosting workshops for young dental practitioners. Today, he'll be sharing his expertise on Leaford and beyond mid-face fracture. We are honored to have him with us virtually. So let's get started and hand over the session to Dr. Mujtaba Nadeem.
Assalamu alaikum. Thank you, Dr. Mesa, for such a good introduction. I hope everyone is with me. I can see the comments. If anybody has a query, has anything to say, you're welcome. I like a good discussion with the audience, so you're free to say anything. Walaikum salam. Uh, ये फातिमा जाहिद आपने वालेकुम सलाम ही कहा है अस्सलाम वालेकुम. Okay, so I'll start. Uh, so the topic assigned to me was a mid-face fracture. How would you manage these kind of cases? So we have a roadmap. If you consider a fracture, there are things that you need to discuss. A basic discussion point would be whether you know what a fracture is, of how or where the fracture propagates. That is the first step. But if once you're clear with the fracture lines and everything, there are certain steps you need to understand. Every fracture will have a certain complaint that will be presented. Every fracture. If a mandible fracture there will be complaints specific to mandible. There, if there's a mid-face fracture, there will be complaints specific to midface. If a fracture is of a zygomatic bone, there will be complaints specific to zygomatic bone, and so on, for nose, for orbit, for frontal bone. And then the from start to finish, you get to that exact fracture once you take in the history, take in the clinical examinations, you investigate further into the x-rays, and every step leads you to the exact fracture. So every fracture, like we are discussing the midface, it will have a very specific set of complaints. And yes, once we'll go into the clinical examination, every fracture will have a different clinical examination, or you can say specific points to uh, search for in clinical examination for a certain type of fracture. So in clinical examination for mid-face fractures, yes, there are certain points as well. Then we can confirm those in the radiographs, x-rays, CT scans. And then once we have formulated that what kind of fracture we're dealing with, how much has it propagated, what damage has it done, whether we need to fix it or not, we formulate a diagnosis. And then once we reach to a diagnosis, we form a treatment plan whether to address it or not. Now once you plan to address it, what is that procedure? How would you perform that procedure? And then once you performed it, how would you follow it up? So this is a basic roadmap to manage any kind of fracture. So I'll start with the anatomy part. You always start with a question of, let's say if I'm dealing with a midface or a mandibular fracture, then what actually constitutes that part? What bones are involved in that fracture? As you can see in this picture, the there are certain highlights. Uh, we have divided the cranium and the facial skeleton into some parts. The mid face has been divided into an upper compartment, a centralized portion in upper, intermediate, and lower. Uh, the middle part is highlighted with yellow. Upper one is slightly darker shade of yellow or orange, and the lower part is brownish. And then you can see the lateral compartment, that is the zygomatic bone, and the orbit is separately labeled. And then we have the frontal bone in the superior part, that is labeled green. So if you understand, if you want to understand what kind of specific complaints the mid-face fracture will uh, be presented with, just ask yourself this: as what are structures present in this region? There's always, yes, there's a nose present in the center. Orbit is just adjacent to the maxillary bone. We have teeth. There will be a problem with the teeth. Then we have an infraorbital foramen in the middle compartment, just below this labeled ICMP. So if you understand the whole adjacent structures, you will get to know of what the exact specific complaints the patient will address. So from the start, you get an idea that yes, I'm dealing with a mid-face fracture, or I'm dealing with a zygomatic bone fracture, or I'm dealing with a mandibular fracture. So the initial complaint, already the initial complaint gives you an idea of what the actual fracture is. So just to set up a brief understanding of our mid-facial fractures, we have divided or categorized into a very basics uh, category or classification. The midface is classified into three fractures, namely Leafort 1, a Leafort 2 fracture, and a Leafort 3 fracture. One is basic, a subapical fracture that separates the dental portion or the dentate portion of the maxilla from the maxillary bone. The Leafort 2 fracture separates maxillary bone with the nasal complex from this cranium. So you have zygomatic bone and frontal bone separated from this nasal complex and the maxillary. So LeFo2 will separate maxillary bone along with nasal complex from this cranium. And then if you add the zygomatic bone into this separated area, it will become LeFo3. So in a LeFo3 fracture, the zygomatic bone, maxillary bone, and the nasal complex will be separated from the cranium. So this is a basic uh, understanding of what actually we are dealing with when we say that Leafort 1, Leafort 2, or Leafort 3. So considering this, if you remember the introductory statement that every fracture will have specific complaints because every fracture will be adjacent to the specific anatomical uh, area or a region. So as you see, mid face has nose in it. So there will always be either blood coming through the nose, you can say a CSF leak due to fracture of the cribriform plate. See, so first would be sorry, for example, patient complains that I have runny nose after a fracture and it has not stopped, and it is clear. First it was blood mixed with blood, now it's clear. So you get an idea. It's not just mid-face fracture. It's the mid-face fracture is communicating with the uh, cranium and CSF, and there is CSF leakage somewhere. So then we can address that thing first. And next, if you consider the anatomy of the maxillary bone, it's slightly, if you remember in your first year session, the anatomy, and when you were reading a norma basalis, there's a clivus, there's a I will inshallah show it in the next picture. The maxillary is a slightly slanting bone. It slants posteriorly, and you push it back, the posterior region prematurely touches first, and the anterior portion is it does not come in contact. So it's a very typical complaint of a LeFor2 fracture that there's always an anterior open bite in that area, that because of the posterior teeth closing prematurely. So anterior teeth will always will remain open because the fractured maxilla is pushed backwards and slightly downwards from the posterior end. So the posterior molar teeth will prematurely come in contact, leaving the anterior teeth open. So in the adjacent picture, in this you can see a CT scan. There is a You will never find a very typical LeFor2 fracture. In this case, if you can see, there's a the maxillary bone and the nasal complex is separated from this zygomatic bone. Here you can see a very typical LeFor2 fracture with a LeFort1 compartment. You can say a very high level LeFort1. And in this, we can slightly see a separation in the zygomatic. Uh, I hope this cursor is working. But so, can I use a cursor here? No. So, okay, so in this CT scan, this is a 3D reconstruction of a CT scan. You can see it's not a very typical fracture, but the right side shows a LeFor2 fracture and the left side shows a LeFor3 fracture. But in this, just want to point your attention to that the anterior teeth have an anterior open bite because of the posterior teeth prematurely coming into contact. So one of the specific complaints of a midface fracture would be an anterior open bite. So now we're discussing that the maxilla is pushed backwards. There's always be a dish face deformity. Dish face meaning the central portion of your face will be posteriorly pushed. So a convex profile will be formed. Now, I hope you guys can answer this in your comments. Uh, Ecchymosis is just a very basic. If you want to understand, ecchymosis is just accumulation of blood in any layer of your skin, right? It can be subconjunctival, as you can see in the left side of the picture, and in the right you have periorbital ecchymosis, which is the blood accumulating in the layers of the eyelids. Now, if you compare these two photos, the the person that is closed eyes because of the edema, the color is blue, which is the same blood, but in the right side or in left picture, the color is still red. So once we say subconjunctival ecchymosis or subconjunctival hemorrhage, it stays red, but whenever you get a bruise on hand or any other area, it stays blue. So does anybody have an idea of what this is actually, or why does blood that accumulates between the skin layers turns blue, and this blood that accumulates just under conjunctiva remains red? Well, I hope you guys can answer. I hope any answer comes, I'll answer it in later slides. But I hope you guys are answering it or not. Just to give you guys a hint, I hope somebody answers. Just to give you a hint, it has to do with the thickness of the superficial layer. So answer आता है तो I'll ask. So just on the theme that we're discussing, the specific complaints that the midfacial fractures will present with, you see there's the infraorbital foramen that this the picture, the green thing, the green area marked, everything that is green constitutes a LeFor2 fracture. So if you see the infraorbital foramen, it's inside that fracture session, inside that fracture area. And once this maxillary bone along with the nasal complex is fractured, there will always be a trauma to the infraorbital nerve. And considering the trauma to the infraorbital nerve, there will be a paresthesia on the upper lip, the side of the nose, and some form of that cheek. So patient will complain that this area is numb, or even if a LeFor2, since it's bilateral, a patient can say his whole upper lip is numb. There might be a pressure on that foramen that is compressing the nerve. If we reduce it in its original place, the pressure might relieve and the paresthesia will eventually come back to normal. So, okay, so this is a very good uh, learning exercise. Just to give you guys a scenario, just imagine we have a patient who suffered a injury to a face, a very blunt injury, let's say, that has no facial lacerations. But once we give a command to check her visual range, we ask the patient, as in the uh, photograph mentioned B, to look on the left. We see both eyeballs looking at the left. In the picture marked C, we've ordered the patient, asked the patient to see right, extreme right. The patient sees extreme right. Nothing, not as wrong, and nothing wrong here. In the picture labeled D, we asked the patient to look up, but on the right eye, she was able to do so, but in the left eye, it's only looking straight. It's unable to move upwards. So if this is a in the picture labeled C, this is a coronal slice of a CT scan. If you can compare these are two orbits, and if you can clearly uh, slightly focus, you can even see the extraocular muscles in this eyeball, and you can see us in the inferior part of this uh, the globe, the orbit. You can see slight tissue that has protruded from this floor. So we call it a trapdoor sign in a CT scan, that the orbital tissue, the extraocular tissue, is trapped between the bones of the orbital floor. And once we try to move the eyeball, since the entrapment is there, the eyeball will not be able to move. So this is a very typical sign of a midface fracture, or a typical sign of an entrapment in the orbital floor. So now, considering you get an idea of what specific signs you are getting, and then you have an idea, yes, I'm dealing with a midface fracture, then our examination basically focuses on a midface. Our for look for midfacial fractures where it could have been. So just if you want to prepare your armamentarium, you need gloves, wooden stick, you need light, uh, saline start, and then a nasal retractor, just to see if any hematoma is there. Um, I think this is covered in the previous lecture as well. Uh, since the patient is coming to your OPD, is perfectly all right. It's just the uh, fractures that the patient has been sent to you for examination of the fractures. The initial emergency management has been done in the emergency or accident and emergency ward. So we don't need to start an ABCD protocol now, because the patient is coming into an OPD. But yes, if you're in an emergency scenario, then we do not look for a secondary survey. Once we stabilize the patient, then we go for a secondary examination, secondary survey and examination. So now, since we expect that the patient is stable, and now we're only dealing with the facial fractures, then you can start your uh, examination. So now you have an idea of the specific complaints. Now we'll go look forward to a specific examination for a midface, just to look for specific things that come into a midfacial fractures. If you compare both these images, you can clearly identify that one picture shows a bilateral presentation and one picture is a unilateral presentation. So initially in your mind, you already assume that the presentation that is unilateral will always be a unilateral fracture inside in the bone, right? And in a bilateral fracture, in a bilateral presentation, yes, there will be fractures on both sides of the midline. So first, ophthalmic examination is very important. It gives you a whole lot of idea before you even start to clinically examine anything. Before I start on in inspection is just to determine if you see any bruise, ecchymosis that will lead you, that will guide you once you will clinically examine and when you palpate things. Okay, very nice. Dr. Kiran has answered that conjunctiva takes oxygen directly. Yes, very nice. It's because the conjunctiva is just one cell layer thick, and it's the oxygen diffusion is very easy, so it stays red. The only reason I emphasize this because even after 1 or 2 weeks, a patient comes and says my eye is still red, and they make a very whole lot of fuss about it. So you need to know why exactly that is red and why your bruise, anything that is uh, any bruise that comes on your skin is blue. So need to educate our patient as well that it is a normal thing that has occurred after an injury, and it will go, but it will, yes, stay red, and it will fade away gradually. So good work, Dr. Kiran. So ophthalmic examination is very important in the start. You get to know the visual range of visual range. If the range is all right, there's no entrapment. If there's no issue with the visual acuity, the orbit is all right. There's no trauma to the nerves or anything. And then do this is a check to examine the pupil level, the globe level, or the both globes are at the same level or not. If just to put it out there, uh, since the eyeball is inside a bony cavity, if the bony cavity expands or compresses, yes, it will change the level or the position of the globe. So if a fracture involves the bony orbit, the position of the eyeball will change. So just if you examine the pupillary level or the level or from the above, that is the bird's eye view, the pupil level, if both are at the same level, then we don't need to do anything. But if one or the other is at a different level, then we need to examine further of whether which side is the faulty side. So I hope you guys can see this. This is a worm's eye view from a snail's point of view. The previous one was bird's eye view. This is the from the bottom side. On the left side, both pupils are at the same level. But on the right picture, you can see the patient's left eye is slightly inside or posterior. We call it ophthalmos, right? Does anybody has any idea of how this could have been? Just imagine a globe, just imagine a bony cavity which has a globe in it. So if you expand that bony cavity, the eyeball will further sink in. So in the left eye, the bony cavity has expanded either through fracture or the anything, but the bony cavity had expanded and there's the eyeball is slightly sunken. So if just if the eyeballs are not at the same position, obviously both eyeballs have to be in the same position to record the same image, and then both images go into the brain and then they're merged, and then what you see is that cumulative image. But if two eyeballs do not merge on the same image, then you get a double vision, two separate visions giving into your brain. Then that brain accumulates it, and then it still accumulates it, but you get a double vision, two separate visions. If you point one finger, the patient will say I'm seeing it in double. So that gives you an idea that yes, eyeball is not in the same position. So diplopia is a very specific presentation for the midfacial fractures, zygomatic bone fractures, or the fractures that deal with orbital or the naso-orbital ethmoid complex. So once we're into the examination. So just systematically organize your examination. First, let's check the nasal patency. Block one nostril, then try to ask the patient to breathe and then check the other nostril, so you get the patency. Now this is a palpation of the bony rims. Now we want to understand, or we want to find out where there is a bony step or a gap, since the infraorbital rim, the LIFO2 fracture runs through the infraorbital rim. So if there's a step or a bony gap or an irregularity or even a tenderness on the infraorbital rim, that will give you an idea, yes, there's a fracture in on that infraorbital rim, and you have to check it bilaterally. And if you can palpate your own eye, you don't have to palpate it from the front. Always slightly go inside. You need to find that rim, slightly go inside and palpate that rim, not just from the front. You have to go slightly inside so that you palpate that rim. And then once you have palpated the orbital rim and we have checked the nose, then we can check the zygomatic arch. Slightly move your finger from the front of the ear to the midface cheek. Check any area of bony overlap, bony fracture, area of tenderness. If there's a fracture present, there will be an area of tenderness. If there's a fracture present, there will be a bony step, a flattening, anything. You will find anything if there's. So once you've cleared with the extraoral exam, now we look forward into an intraoral exam. Just to these are the things that we look for in an intraoral exam. Obviously, when there will be a fracture, there will be some open area or laceration, or there will be an asymmetry. Slightly something will be moved to the left or right. There may be a trauma to the teeth. Some tooth might be luxated, some tooth might be chipped off, the enamel might be chipped off. So you need to check for any irregularities. Lacerations, obviously an area of laceration will give you an idea that yes, a bony fracture will be lying inside there. So, and obviously check both side. If you yes, examine a fracture, always check for its mobility, whether this fracture that has yes happened is now mobile or not. If a fracture is not mobile, it has healed in some way. And then if it's not healed in the proper location, you'll have to refracture it and then place it in the original position. So then you need to check whether the fracture line, the fracture segments are mobile or not. And then since in the intraoral exam of a midface fracture, the maxilla, yes, we need to hold that maxilla, we'll see in the next slide. The palate is of utmost importance because it communicates with the nasal cavity. And if you don't close the gap, or if you don't close the bony wall, or you don't wall off this uh, separation, there will be an oro-enteral communication afterwards, and it's a very difficult. It's not exactly very difficult, but the thing turns into a very technical issue because this thing needs then a two-layered closure. But initially, if you just close it, then it's a very simple and effective means of stopping the two cavities to merge into one, the oral cavity and the nasal cavity. So this is if a picture showing you have you're holding the maxilla, the thumb is on the buccal side and the finger is on the palate, and then our other hand basically checks the mobility of the maxilla at the certain levels of the leaf foot. So if our hand, as you can see here, this is checking which level, since it is on the lateral rim of the eyeball of the orbit. Well, I hope this was a okay. You can say in the comments, but yes, it's a leaf foot 3. This picture is a leaf foot 3 fracture mobility testing. And then if you want to test the mobility of a LIFO2, then our fingers will be either on the infraorbital rim, the index finger on this rim, and the index finger on one rim and the thumb on the other. And then we move the maxilla from our dominant hand and check its mobility, whether the maxilla is fractured at a LeFo2 level or not. And then in the picture on the left, you can see a thumb and a finger. You can do this one by one. We're checking a tenderness and the cross mobility of the maxilla. You need to palpate the zygomaticomaxillary buttresses. If they're tender, yes, there will be a fracture there. Sometimes when the patient presents after 1 or 2 weeks, yes, the tenderness is not there, but there will be a step because inflammation has subsided over that time, and then there will be a fracture will be visible more. This is a picture showing mobility of the LeFo2 fracture at the nasal complex and the frontal nasal suture, and then at the infraorbitral rim. uh, just move it in every direction possible so that any fracture that is you get to uh, check whether the mobility is there or not. Sometimes it's just not very specific. In the anterior posterior, there is no mobility. In anterior posterior, there's mobility in the side to side, so you need to check whether there's mobility or not. Check for this nasal fractures. Hold it with two fingers, two hands, and then move it slightly differentially. If there's a fracture, there will be a sound produced, there will be a fracture mobile segments. Now, once you've had an idea of what the clinical examination has given you, you need to confirm it with your diagnostic aids that are x-rays or a CT scan, and then we'll check it later. As discussed previously, McGregor and Campbell lines, these help you to look for what to look for in a paranasal sinus X-ray occipitomental view, so that gives you an idea of where the fracture lines will be. I hope there was a pointer here, but if you can trace this blue line, you have to trace this blue line that gives you the idea of a fracture at the zygomaticomaxillary buttress and on the either side of the midline. As you can see this pointed arrow, this shows a bony segment fracture in the left zygomaticomaxillary buttress. So this is clearly a separation sign, bony gap in this area. These are discussed. I think this exact picture has been discussed in the previous lecture, so I'll move forwards. This is a 3D reconstruction. It's a very typical LeFo2 fracture. If you can see a pyramidal shape extending from the one infraorbital rim to the nasofrontal suture, and then extending till the other infraorbital rim, and then extending downwards till the zygomaticomaxillary buttresses. This is again a picture in which, if you recall, if we discussed a girl, we asked the girl to uh, move her eyeball upwards, look left, to look right, and then she was unable to look upwards. This is a typical trapdoor sign. The solid arrow, this is pointing towards the soft tissue entrapment in the orbital floor. And then once you correct it, the soft tissue that was entrapped and the bony segments, if you reconstruct the orbital floor, all of these segments will be pulled or pushed inside, and there will be a mesh plate present over there so that the segments don't sag into this bony, the maxillary sinus. Now, just to summarize what we have learned into this 3D CT, this is a fractured maxilla on the level of the LeFo2, and then on this other side as well, the maxilla is slightly pushed on the left side with premature contact occurring in the right side posterior molars. There is comminution in the right infraorbital rim. The left infraorbital rim is there's a LeFo1 compartment as well in the left side, and a proper LeFo2 fracture. The both zygomatic bones are stable. The maxilla is fractured on a LeFo2 level, and yes, there's a nasal compartment as well. The same picture with a different angle, you can appreciate the separation in the right side of the maxillary bone, which is And if you correct this maxillary deviation, it is the right side, the zygomatic or maxillary buttress, the separation uh, will be corrected. If this maxilla, that deviation of the maxilla that is towards the left side, it will be corrected by positioning it towards the right. So once you have understood or and formulated your diagnosis, how would you treat a LIFO2 case or a mid-face fractures? So there are different options. I'll discuss these with you. Now, this is a LIFO2 fracture. One is the frontal view and then lateral view, profile view and a lateral view. So this is, as you can see in this fracture, there is still slight anterior open bite, and we can't leave this fracture as such. If you leave it, there will be an open bite and the patient will heal exactly at this stage, and the open bite will be permanent. As compared to this fracture, this is exactly a hairline fracture. There's no displacement, it's just fracture has occurred, but the fracture segments have not moved anywhere. There is a line, but we don't need to fix them. So yes, we just, and if there might be some plastic deformity of the maxillary bone, so since we have the dentition with us, we can uh, close both jaws, and once we close both jaws in a perfect occlusion, we can assume yes, the bone is also in the perfect position since occlusion is there, since the mandible has come in contact with maxilla in a perfect occlusion. But to my question then again comes, then if you connect mandible with maxilla, but maxilla is fractured from the cranium at a level of LIFO 2, let's say, or LIFO 1, then whenever the patient will try to open it, then there will be a pull on this fracture segment. It might never heal, or there will always be a pull. So how to counter that pull? We can always put a stop. We can always put a stop to this maxillary bone being pulled downwards. That is a circumzygomatic wiring, or we can actually fix this with mini plates. This is an eyelets. These are eyelet wiring that you can. Okay, fixation. Mansoor Ahmed, I'm not quite sure fixation by fixation is what you want. My question was that how would you stop the lengthening of this face once you've put the maxilla and mandible into MF? Yes, fixation is one part, but a fracture that is uh, least displaced and you have just put it into an MF and then there's a pull on this maxillary bone, then what forms of things we can give in this case which can stop the maxilla being pulled downwards? So fixation is yes, one thing, very nice. And there are many ways to do an MF. One is the eyelet wiring. You place a, this is an eye, as you can see in the leftmost picture, an eyelet. You place it in between two teeth. The one eye in the one eye in one in the eye in both the jaws. You connect it with a tie wire or a straight wire and then twist it to tighten it up, and then you close the jaws, upper and lower jaws. So you put the maxilla and mandible into a fixation through eyelet wiring. So just coming to the point again, that once we'll put the both bones into MF, it will cause a slight pull on the fracture segments. So how to stop this thing? To stop this thing, we can initially place a wire around the zygomatic bone and then place the maxilla into a circumzygomatic wiring or a suspension that does not allow the maxilla to lengthen, as the mandible puts its force or pulls it towards down. So you can stop it like this. A better way is to actually fix the fracture segments through open reduction and internal fixation. So we're now opening it, or opening, by opening means we actually going to that fracture, and actually going towards that fracture means you're exposing the layers over the bone, you're exposing that bony fracture. So we can approach this maxillary leaf-O2 fracture through transoral vestibular approach. This is a simple incision marked in the vestibule. Uh, this is a simple mucosa and slightly submucosal dissection. It's not even dissection, it's just you feather it off, and then at the end you cut the periosteum, and then with the periosteal elevator you remove and reflect the flap. And then once you reflect the flap, as you can see, this is the buttress, the zygomatico-maxillary buttress just anterior to this periosteal elevator. Just for reference, the right side of the picture, you can see the arch. That is the arch that is visible inside the actual picture. So how to start fixation? Yes, once we have reduced it, the fracture, we have opened it, we have reduced into its original position, then we start our fixation. We want to fix uh, to the adjacent uh, side of the fracture, the mini plate, the holes that are immediate adjacent to the uh, bony segment. Place one and then two, and then you can complete this either two on one side enough, but more the better. So now if you can see, the zygomatico-maxillary buttress is fixed, but the infraorbital rim is still there, and it might cause displacement, or it might cause difficulty, or recurrence, basically, that the original fracture is not reduced properly. So to hold it in place, or to fix it in place, we need to fix on multiple sites, not just one. So to fix in, we need to fix it as well in the infraorbital foramen too. And then now to approach the infraorbital foramen, there are multiple approaches. One is through skin, and one is through conjunctiva. I'll just discuss this through skin. A very basic approach is a subtarsal incision, in which we incise the skin below the level of the tarsal plates. This is a tarsorrhaphy in which upper and lower eyelids have been sutured so that we can retract the lower eyelid skin. We retracted it, marked it. The first incision is just skin layer deep. The next layer is orbicularis oris oculi, and then we slightly puncture it, put our dissecting scissor beneath it, and then cut the orbicularis oculi, and then there's periosteum underneath. Once you've cut the periosteum, the bony rim will be easily visible, and you can put mini plates over this segment. So once you've placed MF, so if now you've fixed that fracture, so if you're very confident in your hardware, you don't need to place the patient in MF, since you've already fixed it. But sometimes our hardware sometimes our screws are not placed into a very good bone, or a very hard bone, and you feel that yes, we need to load it after 2 or 3 weeks. We can place the patient in MF so that the occlusion is stabilized. Patient only takes liquid drinks, liquids, very semi-solid things that can easily the patient can ingest, and then after 2 weeks we can remove this MF. But if you're confident in your hardware placement, and your hardware, and the acceptance of that hardware, you can remove the MF at that time exactly. So basically this concludes the management of a LeFO2 or a mid-phase fractures. uh, you have been a great audience. Thank you so much.
Thank you so much, Dr. Nadeem, for such an informative and engaging session. We truly appreciate the time, knowledge, and experience you have shared with us today. And we are really grateful for you taking out your precious time to be here with us. To our audience, we'd love to hear your thoughts. Please fill out the feedback form in the comment section. Your feedback means a lot to us and motivates us to keep bringing more sessions like this. If anyone has any question, feel free to drop them in the comments as well, and Dr. Nadeem will be happy to answer. Nadeem, I don't think anybody has any questions.
Oh, great. Very nice.
Your session was amazing. It was really insightful.
Thank you. Thank you.
Now, I would like to invite Dr. Kanza Ahmed Chandio, CEO of Experience Dentistry, for poster presentation.
Assalamu alaikum once
Thank you
again,
so
everyone. Thank you so much, Dr. Mujtaba, for that informative session. I was looking really forward to that at this specific session because I've been learning about these treatments in my studies recently, and your lecture actually helped me a lot to clarify a lot of queries that I had, the concepts. So thank you for that, Dr. Mujtaba.
welcome. Welcome.
Okay,
Thank you.
now we will begin. Okay, so we have lots of comment. People are really liking this. That's really nice. That's really nice. I hope it helps everyone with their work, and they will help make sure that others are aware around you as well. Okay, Ms. Fatma Zahid saying thank you, Dr. Mujtaba, for such a well explained and informative session. It was an honor to have been your student at Avicenna. That's really
Thank
nice,
you.
mashallah.
Mashallah. Very nice.
Yeah, Ms. Fatma, if Dr. Mujtaba was your lecturer, then you are really honored to have him one. Then Ms. Subhana is saying, thank you, Dr. Mujtaba. It was informative and you made it easy to grasp. That is exactly what I was talking about. It was very easy to grasp what you were trying to explain. So,
Honored. Thank you.
Noor Fatma is saying, thank you so much. It was an insightful session.
Thank you.
Hassan Javed is saying, thank you so much, sir. All
Thank
right,
you.
Alhamdulillah, this was really nice to have such feedback. Without further ado, I would like to begin with the poster competition. And for that, I will be removing Dr. Mujtaba and Dr. Rumasa from the stage. Okay. All right. Okay. Uh, okay, let's begin. So we had a maxillofacial fracture awareness poster competition. A lot of participants joined. Mashallah, the enthusiasm, we were amazed by it, and we loved it, and we enjoyed it thoroughly. Going through all of the beautiful posters and informative session posters that everybody made. Um, these are our esteemed judges, Dr. Shaheen Ahmed, Dr. Mahrukh Nisar, and Dr. Mujtaba Nadeem and Dr. Maryam Mustafa. They had a mark sheet. They marked each and every poster that was submitted before the deadline. And so, before we jump into who is the winner, let's have a look at the submission hard work. Our first submission was Ms. Fatima Zahid. She is a BDS from the batch of 2020 of Avicenna Medical and Dental College, Lahore. Such a beautiful and informative poster she made. This was very informative. I read it myself very thoroughly because this was the very first submission that we received. Then we have Miss Dua Faisal. This looks very eye catching. Then we have Miss Isha Noor. She is a dental student, third year at JMDC, which is Jinnah Medical and Dental College from Karachi. Really nice to see that we have a variety from different cities of Pakistan. Then we have Miss Dua Faisal. She is a, once again, batchmate of Miss Isha, a third year dental student at Jinnah Medical and Dental College, Karachi. Really thorough with the poster presentation. Then we have Miss Ahmareen Khan. She is a third year dental student at Dow University of Health and Sciences, Karachi. I must say, Karachi dominated with the amount of submissions we received. However, we still have variety and versatility. Let's see. Miss Maryam Iqbal from Fatima Jinnah Dental College dropped her submission. The pictures were very intriguing to catch your eye and understand what is actually this poster about. Then we have Miss Halima Sadia Baloch. This was very well structured, like organized. So this was really fun to read. And she is from Liaquat University of Medical and Health Sciences, LUMS, Jamshoro. Like I said, we have a variety, versatility, alhamdulillah. Then Mr. Abdul Hafiz, he is a dental student, second year at Liaquat University of Medical and Health Sciences, Jamshoro. Uh, Brilliant gradients, really attractive appearance wise. Then we have Miss Sayyida Subhana Rauf, third year dental student of Jinnah Medical and Dental College, Karachi. Uh, the theme and the colors and the structure really well made, and she even added the reference articles. Then we have Miss Sandhya Raj. She is from the Liaquat University of Medical Health and Sciences, Jamshoro once again. Uh, the all of it is animated, so it can be catchy, but at the same time isn't gruesome enough to distract normal public, right? Then we have Miss Tanzila Fatima, a dental student, third year at Liaquat University of Medical Health and Sciences, Jamshoro. Love the gradients, love the information that is there. Public awareness message bhi diya hua hai isme, so that's really nice, mashallah. Love the creativity. This is Miss Aliza Amjad. She is a third year dental student at Sir Syed College of Medical Sciences. This was actually a uh, GIF, right? The pictures, the animations were moving, and we could not do that, so we just added the picture. But really love the animations that she added, and as well as the pointer that she made at the end, that fractures don't just break bones, they break lives. Stay protected. Well done, Miss Aliza. Let's see next. Miss Ikra Sheikh, graduated from Bahria University in 2022. Love to see that the graduates are active in the participations regarding their dental community. It talks about the causes and symptoms, and the pictures are so well structured. Really love it. And as well as at the end, the public awareness message. Really brilliantly made, Dr. Ikra. Miss Bisma Khan, Jinnah Medical and Dental College, dental student, third year, Karachi. Once again, really love the theme, the animations, and the information that was presented here, to the point for public event. Then Miss Khatija Najam, she presented her poster. This was very um, technology wise, it was very catchy. And then we have Miss Hana Fahim. She's a house officer at Jinnah Medical University, SIOHS, Karachi. Very well made. Like how it was structured, and like that the animated pictures that she added, and as well as the skull picture. So Miss Samina Elias Nena Maiman from Liaquat University of Medical Sciences, Jamshoro. Love the structure, love the awareness element that she add. It was really nice, mashallah. The information was really good. Miss Tehniyat Fatma, a DS2 at Karachi Metropolitan University, formerly the KMDC from Karachi. This was very unique because it has, the mandible, and then it is introducing all of the information that could possibly be there, and that could possibly be added for the people and for the dental community in essence. So this was really, really, really nice, mashallah. And then we have Miss Sayyida Ariba Batul. She is a DS3 at Dr. Ishratul Ibad Khan Institute of Oral Health Sciences, and this is from Karachi. This was very unique, a dark themed one, and really catchy. So, Ms. Laba Rehan, a house officer at Janassan Medical University from Karachi. The colors are really popping out. So this was really nice, including the public awareness message at the end. Then we have Ms. Sana Farheen from the Jinnah Medical Dental College, JMDC, Karachi, at and she's a dental student, third year dental student. She's a third year dental student, and it's really nice to see that the students are presenting with such creative and such informative posters. So this is really inspiring as well. So I would like to say lastly that thank you to all the participants for your enthusiasm, your creativity, and the effort in making the poster that raises the awareness about maxillofacial fractures. Even if you did not secure a position today, your work has a value and it contributes to a cause that impacts lives, okay? Each participant will be awarded a certificate of participation acknowledging their dedication and effort. And we hope your work continues to inspire awareness in the community and promotes public understanding. Then we have, let's see, and the winners are drum rolls, please. Let's see. For the third position, we had a tie between three participants, Miss Halima Sadia, Miss Samina Elias, and Miss Tahniyat Fatima. So, congratulations to you guys. You are at the third position. Let's see who's the next one. The second place. The second place is Dr. Ikra Sheikh. Amazing, amazing, amazingly made. Each of the participants. Do not get disappointed if you did not secure a position. Your commitment will bear fruits. Okay. The first position is Miss Hana Fahim. Congratulations to all of the participants. The winners will receive certificate and they will receive a special award as token for appreciation or for their outstanding work. And I would request all of these winners to send us a email on our official email and with their full name, with their position that they want, and with their complete email. Okay. So, before we end this, I would like to thank the participant for their contribution, and we extend our heartfelt gratitude towards the judges for their time and expertise in evaluating these entries. Once again, thank you to all the participants, judges, and supporters of this event. We hope this initiative will spark more conversations, awareness, and education about maxillofacial fracture prevention and care. So, that is all about the poster competition. I will now move towards the closing remarks of today's summit. This is our day two, the final day of Maxillofacial Fracture Summit. And I would like to begin by saying that as we come to a conclusion of one of a kind maxillofacial fracture virtual summit that we had today, I truly believe today has been a milestone for all of us. The knowledge shared here will help not only enhancing our clinical understanding, but also in raising the much needed awareness on this crucial subject. I am deeply grateful to our esteemed speakers, Dr. Shaheen Ahmed, Dr. Mariam Mustafa, the international speaker, Dr. Mahrukh Nisar, and Dr. Mujtaba Nadeem for sharing their valuable expertise and experiences with us. Your contribution have made this summit really, really impactful. A heartfelt thank you to the dedicated team for their tireless effort, and especially thanks to Dr. Adan, the CEO, for carrying the huge load of organizational work. I also extend my gratitude to our hosts and organizers, Ms. Laiba Iftikhar, Dr. Azaratta Muhammad, Dr. Adan herself, and Dr. Rumaisa Javed for ensuring a smooth flow of today's program, Alhamdulillah. And of course, to our wonderful audience, thank you for your active participation, engagement. Really loved that enthusiasm in the comment section and loved the questions that you were asking to Dr. Mahrukh. We hope you gained a valuable knowledge with our speakers in these 2 days in the pre summit and inshallah in the coming post summit. You can apply them in your practices and share with your colleagues, peers, and communities to spread this awareness about the maxillofacial fracture. For those who wish to revisit the talk, this session will be available on our YouTube channel for viewing anytime. We hope it continues to serve as a resource for learning and awareness long after today. Once again, I thank you all for being part of this remarkable event. I am Dr. Kanza Ahmed Chandio, the CEO of Experience Dentistry, and it has been my absolute honor to host and conclude this summit. Together, let's continue to learn, share, and make a difference in this world of dentistry and beyond. And before I bring this to closure, I would like to take a moment and extend our solidarity and prayers to the people of Palestine, Gaza. In these deeply challenging times, we stand with those affected by injustice and we commit ourselves not only to the clinical excellence, but also with humanity, empathy, and justice. So let's keep talking about Palestine and let's not forget the people suffering there. Once again, before I end this, I would like to invite our founder, Dr. Farooq, and he will be sharing few words with us. Assalamu alaikum, Dr. Farooq.
Walaikum salam. Thank you, Dr. Kanza, for introducing. And thank you very much, guys, for putting up a very great 2 days virtual summit. To be honest, it's a very big task organizing it, organizing a kind of a summit which has never been organized first in place in the Pakistan. So it was first type of a virtual summit, which was organized on the topic of maxillofacial fracture. I'm very much proud for the efforts you guys have put in organizing it, and I'm very deeply thankful to all the speakers and all the participants who made this summit huge successful. I was very much inspired by the efforts of all the volunteers who were involved in the 14 days campaign of maxillofacial fracture awareness, as well as I was also very much surprised by the very great contribution and commitment in making the poster competition of all the participants who participated in it. So I wish all my best wishes to every one of you, and to all the organizers and all the team of Experience Industry who made this 2 days virtual summit possible and made it a very successful event. So without any ado, I would like you guys to close it, and thank you very much for putting this session. Thank you.
Thank you so much for that, Dr. Farooq. And all right, we'll be closing in. Dr. Mahrukh is with us. Dr. Mahrukh, would you like to say anything before leaving?
Just great, thank you, and a huge shout out to you all for organizing this. This has been kind of a game changer, I would say. So, all the best. Continue doing what you're doing, and
Thank you so
thank you.
much.
Allah Hafiz.
Allah Hafiz. Thank you so much for that. All right, with that, we conclude our today's session. Thank you, everyone, and inshallah, see you in the next upcoming webinars. Allah Hafiz.